Hey, welcome back to Pharmacology. Today we're going to go through the antiarrhythmic drugs. So there's a couple, some will block the potassium channels, and that is going to block either phase 1 or phase 2. So it's going to block the channels from opening in phase 1, and it's going to block the potassium efflux in phase 2. In a calcium channel blocker, it's going to work on phase 1. It's going to prolong the QRS complex. It's going to continue the action potential. It's going to slow the rate, but it's going to elongate the action potential of time. A potassium channel blockade will also prolong QT. So not just the contractility, but also the diastole of the ventricles. Or ventricular systole, is going to prolong the systole. Calcium channel blockers are going to prolong ST. So this is going to only prolong the ventricular systole. So class 1 is one double quarter pounder. It's disopyramide, quinidine, and procainamide. These are pretty important mnemonics. There are subclasses of class 1. There would be A, B, and C. And we remember them through Bachmann. So phase 1 is going to be Batman's ear. Phase 2 is going to be calcium and potassium plateau. C is Kira phase. This is going to be part of the class 1 sodium channel blockers, and those would be more fries, please. So morazine, flecamide, and propranolone. Phase 3 is going to be repolarization and after. So A is going to be double quarter pounder. So like I said again, disopyramide, quinidine, and procainamide. And B for the sodium channel blockers. Class 1B would be lettuce, tomato, and tomato. So lidocaine, mexetlatine, not really used as much as lidocaine, and tocanide. These are more commonly used in the hospital. So Bachmann, important to remember. Class 2 are going to be your beta blockers, and remember, ends in LOL. And class 3 are your potassium channel blockers, and class 4 are your calcium channel blockers, and we'll go through them. So the sodium channel blockers will bind and block fast sodium channels, and it slows the depolarization in the non-nodal cardiomyocytes. So it's going to slow the depolarization in the heart muscle itself. And it decreases the slope of the phase 0 by decreasing the amplitude of the action potential, as you can see here. 1B is not going to do too much. 1A, a little bit more. 1C is the one that will decrease the amplitude the most. So quinidine, 1A is like moderate. And the class 1C is the strongest blocker. So you want to use these to treat tachycardia and re-entry currents. So in these particular patients, there's going to be like a delta wave. We'll go through that later, but it inhibits the vagoactivity, and like I said, here's the effectiveness, and the increasing the effective refractory period. As you can see here, the refractory period is like the plateau, the length of the plateau. Okay, so subclass 1A, so double quarter pounder, disopyramide, quinidine, and procainamide. I really recommend just saying these names again and again and again until you remember them. They also block the potassium channels. and they treat atrial fibrillation, flutter, supraventricular tachycardia, and ventricular tachycardia. And this is it. Ventricular tachycardia is very dangerous because the patient can die, like from cardiac arrest, very quick. Okay, quinidine has some unfortunate adverse drug reactions, such as GI intolerance, synchronism, antimuscarinic effects, so that's going to be your sludge effects, A1 adrenergic blockade, and tachycardia. Quinidine is also weight-based, so if you take it with Tums, it will increase the absorption, increase the free concentration in the blood. The most dangerous complication is the torsade de pointes. So it's French for pointed, right? And that is going to be your ventricular tachycardia. Drug-induced lupus can also cause it, and also the subclass 1A can also treat. So we'll go through this a lot more in pathology, but lupus is basically the anti-nuclear antibodies and antihistones, so it's going to attack the DNA of the cells. We differentiate it from true lupus erythematosus because there's no anti-double-stranded DNA antibodies. Instead, this has the antiphospholipid antibodies. Procainamide can cause lung diseases, and this is what I was talking about, the Wolff-Parkinson-White. It results in the delta wave, and it's basically re-entry currents. So in a normal heart, it like goes from point A to point B, but in the Wolff-Parkinson-White syndrome, the current doesn't go from point A to point B. It goes in the circuit and it comes back to point A every time, so causing like a flutter. So it will cause the supraventricular tachycardia, and that alternates with ventricular tachycardia. The supraventricular tachycardia worsens using calcium channel blockers or digoxin. So usually ditch is used to treat atrial fibrillation, right? So if it worsens after using ditch, you have to use procainamide instead. And that will kind of treat the symptoms, but the true treatment is ablation of the extra tissue. So if we, like, let's say ablate this, it will be going, the current will go like to the correct nodes, right? There's not going to be a re-entrance. Okay, subclass B, lettuce, mayo, and tomato, sorry. It's lidocaine, mexilatine, and tocanamide. These will block the sodium channels in an inactivated depolarization state, so it's not going to change the heart rate. Instead, it's going to regulate it, right? There's not going to increase or decrease, it's just going to regulate it. By treating the ventricular tachycardia, ischemic myocytes, so after a heart attack, this is very useful. And this has the least effect on the upstroke of the action potential of all of the class 1 drugs. So this will have the lowest amount of efficacy. Okay, so lidocaine is usually used for local anesthesia, but it's also used to treat ischemic ventricular tachycardia and arrhythmias in ditch overdoses. Unfortunately, there's a lot of like neurological effects, so use with caution. And high doses, the concern is sudden cardiac death thanks to the hypotension. Lidocaine is special because it converts the unidirectional block into bidirectional blocks. So the bidirectional block can block like both, let's say, pressure sensors and vagal output, so that can increase the hypotension even more. Okay, 1C, more fries, please. So moxazine, flecainide, and propafenone. Sorry, these names are very hard to pronounce. These are the most potent, and that's because they block the activated sodium channel in the open state. So in the open state, this is going to affect heart rate. Of course, it affects heart rate, so it treats AFib and ventricular arrhythmia. And we want to treat these because of thrombus formation in AFib can lead to strokes. Adverse drug reactions are going to be GI disturbances, visual disturbances, but more importantly, the sudden cardiac death. So it's a double-edged sword, all of these. Antiarrhythmia, we're trying to correct the arrhythmia, but it can also worsen it. That's why you have to be very, very careful. Okay, so beta blockers block B1 receptors in the heart, don't allow the binding of adrenergic hormones, so it will suppress the sympathetic effects. And there's the non-selective versus selective, yada yada yada. Okay, we also use these to control arrhythmia in pheochromocytoma and during anesthesia. We used it after myocardial infarction, also with angina, hypertension. We don't want to give it to, especially the non-selective beta blockers. We do not want to give it to people with asthma, diabetic patients, because remember, it hides the signs of hypoglycemia. Okay, class 3, antiarrhythmics is bad. So ibutylide, sotalol, bretylium, amiodarone, and dofetilide. These are going to be your potassium channel blockers. They decrease the repolarization and increase ERP. They treat the tachyarrhythmias caused by the re-entry. So it's a treatment, but remember, you have to use ablation to truly cure. Of course, the adverse drug reactions is besides the point, and that's the most dangerous one. Contraindications, we don't use this in people with heart blocks. It make this infinitely worse, or sino-atrial node problems. So this is bad because they are very lipid soluble and can accumulate in the lungs, the liver, and the skin. So since it's a potassium channel blockers, we do not want to use the diuretics that are potassium sparing in conjunction. So do not be giving somebody with amiodarone with, let's say, spironolactone. That will kill the patients for sure. Okay, so the other effects of the class 3 drugs are photosensitization, skin pigmentation, it's also called as blue man syndrome, and these corneal deposits, and that's called cat whiskers. Pulmonary alveolitis and fibrosis is the most common death from amiodarone and bleomycin, which is anti-cancer drug, so can't put these two together. So here's the honeycombing effect. The fibrosis is going to restrict the lungs, not allowing oxygen to come, will allow the patient to expand the lungs to allow adequate oxygen perfusion. So before you start amiodarone, we want to start chest x-ray, make sure patient has, clear lungs. We don't want any fibrosis. And we also give them the pulmonary function test, the liver function test, and the thyroid function test. So amiodarone, while a pretty good drug, you have to be careful about it. Okay, class 4, I and V. Diltiazem and verapamil. We use this in the hospital a lot. These are your calcium channel blockers. Verapamil will block the L-type calcium channel and decrease the calcium-mediated depolarization. So it's used to treat the paroxysmal supraventricular tachycardia along with a flutter and AFib. Of course, it's going to be contraindicated in an AV block because the calcium channel is needed to conduce the action potential. Also, we have to be careful with this. We absolutely do not give this with thiazides because the thiazides will lead to hypercalcemia. This is already a calcium channel blocker. Bad news. Okay, so adenosine will bind with adenosine receptors, and by doing so, it activates the potassium channel, causes hyperpolarization, and depresses the SA nodal activity. So it's going to lead to bradycardia. Also blocks calcium influx, and it increases the ERP by slowing the conduction through the AV node. So this is going to help the heart not only it's just going to help the contractility be more effective. So it's going to allow longer contractions and longer relaxation. So that's why it's the drug of choice in paroxysmal supraventricular tachycardia. The adverse drug reactions aren't too bad. We can deal with flushing, we can deal with hypotension, and we can deal with transient dyspnea. Magnesium sulfate is going to be the acute management of torsades de pointe because magnesium will block the calcium influx, hopefully allowing us to control the heart. Atropine is going to be your muscarinic receptor antagonist. There's a whole nother lecture about this. We're not going to go through it. But we use it to treat bradycardia. Digoxin, AFib, decreased in nodal conduction, and remember from the other lecture, builds up in the heart and the liver, and is toxic. Supraventricular management. Okay, first we want to use your calcium channel blockers in order to control the contractility and the heart rate. Then we use the beta blockers and adenosine and ditch. Ditch is more for management. These are like first line treatment. Ventricular tachycardia management, we use class 1 and 3. And for the Wolff-Parkinson-White, first we use class 1 and 3, and then we use the ablation once we are absolutely sure that this is Wolff-Parkinson-White. AFib, we want to use calcium channel blockers and beta blockers first, and then, if need be, the digoxin and anticoagulant due to the toxicity of ditch. Torsades de pointe, first we're going to try to manage it with the magnesium sulfate long enough for you to go into the heart lab and get a pacemaker inserted. That's it for now. Thank you for your attention and good luck studying.